Professor Achenbach.
Thank you very much. It's a pleasure to be here, and I'm very happy that I can share with you what I think is the state of the art in cardiac CT. We do not have a lot of time, so I'll try to keep it very short so that maybe in the end we still have some time for discussion. You probably all know, let me see how I can advance this. Here we go. You probably all know that CT has gone through tremendous technology development, and the latest CT scanners that can acquire about 300 very thin slices of the heart in just a few seconds, synchronized to the EKG with very high temporal resolution and very high spatial resolution, well below 1 millimeter. And the most frequent indication to use CT imaging of the heart is to visualize the coronary arteries. Here you can see examples of a three-dimensional reconstruction and, more informative, a two-dimensional display of the coronary arteries that gives you a feeling for how accurately CT can visualize the coronary artery system when modern systems of CT are being used. There are some prerequisites. If you look at the state of the art in coronary CT angiography, you should probably be using CT scanners that have at least 64 slices, and with adequate patient preparation, you can do fine with 64 slice CT, even though more advanced scanners will make it easier to obtain good quality images. Patients should have sinus rhythm. There are possibilities to also study patients in arrhythmia, but it's more difficult. Patients have to be able to follow some breath hold commands, and severely overweight patients can be problematic to image by CT. The heart rate should optimally be less than 60 beats per minute, so giving beta blockers prior to the scan is extremely helpful to improve image quality. And of course, we need contrast agent to visualize the lumen of the coronary arteries. Between 50 and 80 milliliters are usually sufficient. And this is a typical example of a high-grade stenosis visualized by coronary CT angiography. Here's another example of a high-grade proximal LAD stenosis, and you can see that the radiation dose for modern scanners can be extremely low. With very modern system, doses of less than 1 millisievert are possible. And on the average, at least in Germany currently, the dose for a coronary CT angiogram is approximately 3 to 4 millisieverts, which is the same range as an invasive angiogram. The accuracy to identify coronary stenosis is very high. The sensitivity in a recent meta-analysis of 3,700 patients was 96%. The specificity of 81% to identify coronary artery stenosis is somewhat lower, but for a non-invasive technique, these are very, very high accuracy values, especially the sensitivity around 96%. We don't miss coronary stenosis by coronary CTA. And this means, because we have a very high sensitivity, that if we have a normal coronary CT angiogram, such in this case, we can be absolutely confident that the patient has no coronary artery stenosis, no coronary artery disease, and that no further workup or any other procedure is necessary for the patient. Very reliable to rule out coronary artery disease. There are many data in large registries and also large randomized studies that have shown that using coronary CTA to rule out coronary stenosis goes along with a very high prognostic value. Here's registry data in 35,000 patients that show that if the coronary arteries are normal in coronary CTA, patients do well, the mortality is close to zero, and then with an increasing number of vessels that show stenosis, the mortality increases in this large registry. And there's also the PROMISE trial where 10,000 patients with suspected coronary disease were randomized to either receive coronary CTA or stress testing, and you can see that the outcome of these patients, it was absolutely identical. So you can use CTA just as well as stress testing to work up patients with coronary artery disease. This is also reflected in recent guidelines. The guidelines of the European Society of Cardiology state that if you have a patient with suspected coronary artery disease, you should consider the use of coronary CTA if patients have a relatively low pre-test likelihood and if good image quality can be expected. So the use of CTA should be considered. It's a class 2A indication. The same holds true for patients who present with acute chest pain and once again have a relatively low pre-test likelihood. The use of coronary CTA should be considered. And here's a flowchart for stable coronary artery disease. This is what the ESC guidelines suggest. If you have a patient with suspected coronary artery disease, you should look at the patient and consider what imaging modality the patient is suited for. You should look at availability, obviously, and also take into account local expertise. And then there are two options in a patient who has suspected coronary disease: to either go for stress testing to look for ischemia, or if a patient is a suitable candidate for CT, not severely overweight, sinus rhythm, and can hold the breath, then coronary CTA should be considered. And it's a very good technology, especially when the pretest likelihood is relatively low, and the main goal as a cardiologist is to rule out the presence of coronary stenosis. So there is no need to perform coronary CTA, but it's a very good option that we have now available in suitable patients and suitable clinical situations. The patient with suspected coronary disease, in whom we, as a cardiologist, expect that probably there is no stenosis, but we need to know for sure. There's no requirement to use coronary CTA. The guidelines keep it open. You can use stress testing if you want, or coronary CTA. It's not even possible in all patients. In some patients who have arrhythmia, patients who can't hold their breath, patients who are severely overweight, or if they have implanted stents, coronary CTA is not reliable. So in these situations, you should probably go for stress testing. But in many other situations, we have a tool that is very fast, has a reasonable dose, radiation dose. It's extremely reliable to rule out coronary stenosis and has fantastically high prognostic value. We know for sure from very, very large patient cohorts, 10,000 patients, 35,000 patients, that if coronary CTA is normal, patients will not have events and they don't need any further treatment or management. So it's a fantastic tool that we have at our fingertips, but we need to be realistic. I think you want me here, so I give you a realistic view of coronary CTA. There are two things that need to be considered. The first is that image quality is absolutely essential in coronary CTA. When coronary CTA is done, it has to be done with high image quality. If image quality is poor, the typical result will be a false positive examination. A poor quality CT always looks like there are stenosis everywhere. Here's a CT scan that has calcium and motion and poor contrast, and it looks like there are stenosis everywhere, here, here, here. Then in invasive angiography, you can see there are no severe stenosis. Then here's another case where the image quality is poor, and there is the impression that there might be stenosis in this vessel. And in this case, the scan was repeated. This one was done with no heart rate control, very poor breath hold, 64-slice CT, and the scan was repeated with a higher quality scanner. Heart rate was lowered, nitrates were given to the patient, a good breath hold command, and high flow of contrast. And you can see this is the same patient with a good quality and with a poor quality scan. You can see with the good quality scan, you can see there are absolutely no stenosis. So we have to keep this in mind. If CT is done and image quality is poor, we end up with false positive results, which is something that needs to be avoided. So image quality is essential when coronary CTA is used clinically. And when image quality is good, even in challenging situations with a lot of calcium, for example, you can very clearly rule out the presence of coronary stenosis. Image quality, however, is essential. The second issue is something that we cardiologists know very well. The presence of a stenosis does not necessarily mean there's also ischemia. In some situations, the anatomy alone tells us that this is a relevant stenosis. Here's a left main trifurcation, high-grade stenosis in CT and also in invasive angiography. For a patient like this, we don't need ischemia testing. This is a prognostically relevant lesion without ischemia testing. But in many other situations, we have a stenosis in CT or in invasive angiography, and we don't know whether this stenosis causes ischemia. And that's something that needs to be taken into account. When you find a stenosis in CT, in many instances, additional testing for ischemia will be necessary to determine whether the stenosis actually needs treatment. CT offers possibilities to look for ischemia, even with CT. There is FFR-CT, where we simulate fractional flow reserve. There's also the option to do CT myocardial perfusion. I'm just mentioning this, that CT is not only anatomy. If you do the tests accordingly, you can also use it to identify ischemia. Both of these techniques have an accuracy of about 85%. to identify myocardial ischemia. So the two important issues to remember when considering the use of coronary CTA on one hand is that image quality must be kept very high. We need to ensure image quality by very careful data acquisition and by making sure that we're using this technique in appropriate patients, those in whom good image quality can be expected. And the other issue to keep in mind is that not every stenosis causes ischemia, so not every lesion seen in CT angiography requires revascularization. In many cases, we might need to do stress testing first. The clinical application, as I said once again, is mainly to rule out stenosis when considered clinically necessary and the patient is well suited. We see this, we see normal coronary arteries, whether it's in stable chest pain or acute chest pain, we can be extremely confident that the patient needs no further workup and no medication. There's also very interesting data that CT can not only identify stenosis in the coronary artery, but also non-stenotic plaque. Here you can see atherosclerosis in the proximal LAD, calcified and non-calcified plaque. Here's another case with some non-calcified and calcified plaque. Here's a cross-section, and you can see all criteria of a vulnerable lesion with positive remodeling, very little calcification, dark areas within the plaque which probably indicate the presence of a necrotic core. So it has been shown very nicely that the presence of plaque is associated with an increased event risk. Plaque, on the other hand, is very frequent. In many patients, we find plaque. So there's intense research going on at the moment regarding plaque quantification, plaque characterization, and the prognostic implications. It's not a clinical tool at the moment, and I'm very interested to hear the lecture on the vulnerable patient a little bit later in this session to hear what we learn about cardiac CT. I would like to go back for just 1 or 2 minutes to the beginning of what CT currently delivers. We are very much focused on using CT for the coronary arteries, but if you think back, as I said initially, CT acquires approximately 300 slices of the heart in just a few seconds. The temporal resolution is high. The in-plane resolution is high. The resolution in the imaging plane, sorry, this was too fast. Here we go, the resolution in the imaging plane, but also the slice thickness is very thin. And because we have a combination of very thin slices and good in-plane resolution, we have what we call isotropic resolution, and we can slice and reorient our data in any desired plane and retain very, very high spatial resolution. And that's something that other imaging modalities do not deliver. Isotropic spatial resolution, so in any desired plane, you can slice the data in any orientation that you want, and you always keep very, very high fully isotropic spatial resolution. So CT provides not only the coronary arteries, but also for the heart in general, extremely high resolution morphology imaging. This is something that is not frequently needed, but in some cases it can be clinically extremely helpful. And it has been incorporated, for example, into the recent endocarditis ESC guidelines, where the presence of abscesses and other formations that are indicative of endocarditis are one of the major criteria now for diagnosing endocarditis when echocardiography is not sufficient. So using CT for morphology imaging in special situations is becoming more important clinically. It has become very important in the context of structural heart disease interventions, such as TAVI, where you all know that measuring the aortic root geometry and dimensions before the procedure, for example, the size of the annulus, are decisive to ensure maximum success of the TAVI procedure. So for structural heart disease interventions, morphology imaging by CT has become very important. So this is already my summary slide. CT provides high and isotropic spatial resolution. It's mainly used for the coronary arteries, and here, most importantly, to rule out coronary stenosis, and we have very strong prognostic data. It's a diagnostic option to rule out coronary artery disease in the current ESC guidelines, but I would like to emphasize once again that if CT is done, high image quality is of extreme importance. And besides the coronary arteries, CT can also be used for general morphology imaging of the heart in those situations where very high isotropic resolution is required. Thank you very much for your attention.
Thank you very much, Professor Achenbach, for your excellent talk. Would you say that, I noticed that in the however's you showed us, the availability of the scanners and the cost was not an issue. Don't you think that this is an issue here, talking about CT in coronary artery disease?
I did not quite acoustically understand the question.
Would you say that availability of the scanners and cost of the test is an issue in this area?
Yes, absolutely. As I pointed out, CT is only fully useful when image quality is high, which means that you have to have a high quality scanner available. It also means that you have to have a certain volume. If you only do 50 scans per year, the quality of data acquisition and interpretation will not be as high as if you do 800 or 600 scans a year. So, of course, the availability of the technology is important. Cost is equally important, but then again, other stress testing, high-end stress testing, such as MR perfusion imaging and nuclear scans are not significantly less expensive. It depends from country to country, so that is something that can be taken care of. High-end CT systems are becoming more prevalent. We're seeing more and more areas where high-end CT systems are being installed, so I'm confident that the technology will penetrate cardiology increasingly in the years to come.
Okay, are there any questions from the floor? Okay, thank you very much, Professor.
I would like to, Professor, I would like to ask you something. What about the congenital coronary anomalies? I mean, we know that in the young people, the second cause of sudden death is the congenital coronary anomalies. Do you think that this tool has a role to identify people with these problems?
Yes. The CT is the best, in fact, technology to identify the exact course of anomalous coronary arteries. So when there's a suspicion that an anomalous vessel might be present, CT imaging is the test of choice. We have some radiation exposure, so we will not use it as screening the young population for anomalies, but if the suspicion is there, a scan of approximately 1 millisievert will be able to tell you very exactly where the course of the coronary arteries is and whether they are potentially dangerous.
Thank you.
Professor Chufis.
Thank you, Stefan, for an excellent talk. You described very well the indications, let's say, of CT. But if you have to select an exclusive disease where you will exclusively use CT, which disease, which cardiac disease would be the first one?
Well, I think the one area where there's absolutely no option to do anything else is the planning of structural heart disease interventions. If you want to do them really, really well, you can plan them with 3D echo, but it has been shown that CT is better. So in the context of structural heart interventions, I think this is where there is no replacement for CT at the moment. Coronary artery disease can be worked up in different ways, stress testing or CT, so there is an alternative, but high-end structural heart disease interventions do benefit prognostically from CT being performed.
Okay, thank you very much, Professor S.ACHENBACH.